Okay, hi everyone. So we'll get started. My name is Sydney Lee. I'm an autoimmune neurology fellow here at the University of Utah. I'll be moderating the session today. So I think we'll just start with some brief introductions. If you could both tell us your name, where you're working right now, and the population of patients that you tend to see. And here's Dr. Turok, perfect timing. Come have a seat. All right, so I'll hand it, I guess, Dr. Wright, if you want to start.
So I'm Melissa Wright. I am a pediatric autoimmune neurologist, so mostly see pediatric patients. I also have a special interest in patients transitioning from pediatric to adult care. During my fellowship, I saw a lot of adult patients, and so have sort of an interest in that age group of adolescent and young adult in particular. And I practice at Primary Children's and the University of Utah and see all patients with all types of neuroinflammatory disorders.
I'm Yibing Zhang. I'm a neuroimmunology fellow, and I'm training under Dr. Rose, Dr. Wright, and a lot of other people in our autoimmune department. And we'll be working on a project specifically looking at the transition from pediatric multiple sclerosis to kind of the adult side of things.
Great, and we're just doing introductions. So if you can say your name, where you're working, and then what types of patients you care for.
Great. Hi, my name's Dave Turok. I'm a OBGYN, and I'm the director of the Ascent Center for Reproductive Health. And I see people who desire contraception and abortion care and miscarriage care. And I, for many, many years, did the full range of obstetrics and gynecology and provided lots of prenatal care at the community health centers in Salt Lake City.
Great, thank you all. So I think, we'll start maybe just more generally. We know that these rare autoimmune diseases can affect people of all different ages, but there can be some special considerations for pediatric patients versus adult patients. Could you maybe speak a little bit about that? Just anything in particular to keep in mind in the pediatric population?
Yeah, I think a few things in particular in pediatrics is, I mentioned this a little bit in one of the earlier sessions, but in pediatric patients, the differential or the type of different diseases that we're considering from the beginning tends to be a bit broader. So for example, a patient comes in with a set of symptoms that might suggest a neuroinflammatory condition. We're thinking of a broad set of different things, infectious, but also things like genetic conditions, which more typically present at a younger age than, by the time you're an adult, it most likely would have manifested. Sometimes we do see later onset genetic diagnoses, but that is something that I have to be aware of, or that we have to be aware of in pediatric patients. And so a lot of times, even in patients who we're pretty certain it's a neuroinflammatory disorder, we often consider genetic testing, consider other things that might more commonly present in younger patients. So that's one of the big things that we think about. The other thing is that we have to consider how immunotherapy affects pediatric patients. We don't necessarily think that immunotherapy is unsafe in pediatric patients, but we just have to consider how it might affect pediatric patients differently in terms of immunizations. So, that's different in teenagers who maybe have gone through their whole series of immunizations versus a really young child who I'm considering putting on rituximab, for example, who has not gotten their whole full series of vaccines. And so I get a lot of questions about immunizations, a lot of questions about, is it safe to go to school for patients? In my patient population, a lot of families nervous about sending their kids to school just because, anyone who has a child knows how hard it is to prevent germs from spreading in school situations. So those are some of the main considerations that I see in terms of differences, or special considerations that we often think about for pediatric patients.
Great. And I guess any particular differences in how we go about treating pediatric patients versus adult patients?
Yeah, I think a few different considerations. So, you know, Sumaira had joked earlier about what did she call it? The devil's tic tacs for steroids, which I think yes, anybody who's been on steroids can attest to. But I think for pediatric patients, I am very cautious about steroid use. We know that you know, steroids can affect bones and growth in pediatric patients, and that kids are sensitive to side effects of steroids. I mean, adults obviously have side effects from steroids as well, but I'm just very cautious about that and making sure that I'm not doing steroids for longer than we need to be. And so I'm often sort of thinking of a plan B if I'm knowing that long-term immunotherapy is needed, or we're trying to get off steroids and we're not successful to get off steroids, of what we're going to do instead, because I don't want to keep kids on steroids for long-term. It's just not a reasonable option for pediatric patients to be on steroids long-term. So whereas, you know, some it's not that we want to keep adult patients on steroids long-term either, but we might tolerate low doses of steroids for longer periods of time in adult patients than we would in a pediatric patient. So that's one of the big considerations. And then, as I mentioned, vaccines. So it might be that we delay starting immunotherapy or a specific immunotherapy to get vaccines. And not that we would delay treatment, but we would delay starting a specific immunosuppressive therapy and maybe bridge with something else for a time until trying to get vaccinations. Or we might encourage family members to make you know, we always encourage this, but especially encourage family members to make sure that they're up to date on vaccinations. We also have to think about that and ask about vaccinations to see where they're at, and have to have really thorough discussions about that. So for example, a young child who comes in who we need to start on immunosuppressive medication, and we're really not in a situation where we can wait to start that. It's a really thorough discussion with the families about knowing that their child would not be protected against certain vaccine preventable diseases, and that it would likely be quite a while before we'd be able to vaccinate after starting immunosuppressive medications, knowing that some of those would not be able to be done on certain medications. And so just some more discussions surrounding that typically need to happen.
Great, thank you. And now kind of, you know, going more like into the adolescent period, young adulthood, what are some challenges that patients and families might face, you know, as the patient is getting older, maybe transitioning from the pediatric clinic to the adult patient? Is there anything that patients should be aware of, or any tips to kind of help navigate that transition period?
I feel like I'm talking a lot, but I don't know if you want to.
Whoever wants to take it, yeah.
I'll start, and then Melissa, you can jump in. So in our patient population, we found that in the adolescent and kind of this transition period, there is decreased level of adherence to whatever therapy that they're on for their medications. And it's not hard to imagine why that could be the case. Being an adolescent is already really hard, but being an adolescent with a chronic medical condition that requires immunotherapy, maybe every 6 months you have to go in and physically get an infusion. That's really difficult for somebody of that age group when they are having so much transition throughout their life, and maybe they're going into college, and with that, they have to take their chronic condition along as well. Part of it is also the level of independence of the adolescent as well. Are they comfortable talking about their symptoms during the encounter with their physician, because if they had been diagnosed with this condition since childhood, maybe their parents are always with them, maybe their parents are talking about their symptoms. At what point is the actual patient, the adolescent, going to start taking care of their own health and taking charge during those encounters with their physician? Are they going to be able to call into the clinic and make their own appointment, their follow-up appointments, in terms of kind of infusions and their medications? How adherent are they going to be able to be if they're out of their main household? So say they're in college and they're busier, are they going to be adherent to their oral medications? If they're taking oral medications, are they going to be doing every 6 months infusions? Or are there certain periods of time where, because of how busy their life is, because of during that transition, or because of lack of autonomy or control in their type of disease that they have, that they fall behind on those things? And so how can we make that transition period a little bit easier for them? The other part of it is when you transition from pediatric to adults, you get used to your provider who's in pediatric neurology. You've seen them for most of your lifetime, from when you were a child up until adulthood. And all of a sudden you have to go into the adult side, and maybe this provider doesn't know your entire 10-year history of your disease. Someone that doesn't know how you've grown up, maybe you don't have a personal connection to them. How do you feel comfortable with sharing intimate details about your disease with this new provider that you're now seeing? So there's a lot of barriers for adolescents to jump through in order to get through that period of time.
Yeah, I would echo all of that in terms of challenges. I think the other thing that I see is oftentimes, regardless of the age of diagnosis, oftentimes I see this sort of pattern of getting through this acute period, the initial diagnosis, and just families are reeling, just trying to wrap their head around these rare diseases that they've probably never heard of before any of this, and not realizing that this was anything that was going to happen to their child. Or kids not realizing this was anything that was going to happen to themselves. And after that initial period, and sort of realizing and settling into the fact that this might be something that they're dealing with long term, or definitely is something that they're dealing with long term, they start thinking about, what does this actually mean for the future? And especially as kids get older and go into adolescence and teenage years, start thinking about, okay, what does this mean for, when I want to move out of the house, or going to college, or going to, some other, technical training that they want to do, or what does this mean for getting married or having children. And I think that's the questions that a lot of people have much earlier than I would ever expect, or sometimes that we do a good job of asking about if they have those questions. And I find a lot of families asking those questions very early on, even though it's a number of years down the road. And same with transition of care questions. That's a big concern that parents have, is like, what's going to happen when my child turns 18? Or what's going to happen when my child graduates? Are they just going to get kicked out of this clinic? Is it just going to be like a goodbye, figure it out? And so I think those are issues that families are concerned about, that we certainly as providers can do a much better job of discussing, and also sort of preparing for and saying, this is what it might look like, and discussing those issues early.
Yeah, that's great. Thank you. And I think, Dr. Wright, you touched on something that I have heard come up from parents and families every now and then. I think, there's a lot of uncertainty as to what the future might look like. And, there might be some worry about, how things are going to go. And I guess I was wondering if you had any stories or anything that gives you hope, or what you could give to patients who are kind of worrying about that right now, like just in terms of what the future might look like living with one of these diseases?
Yeah, of course, I can't always give specific examples, just protecting other patients' information, but I try to just give generic information about, I have patients who live completely normal lives in terms of are able to have pregnancies on these medications, or this is typically how we approach this with this medication if patients do want to go off to college, and how we approach infusions or things like that. And just sort of talking about this is a way that we do this so that families feel like, okay, we're not alone, like this has been done before and this is what it looks like, I think takes a lot of the uncertainty out of it. And certainly it's a work in progress because these are so new. And so, some of these disease processes, so we're still learning about taking care of them, but learning about taking care of them as patients age is a whole new thing too. But I think hearing that it's been done before, that we have a process for transitioning patients, can be really reassuring to families.
Great, thank you. And then I want to touch also on the topic of family planning, because that has been an area that we're learning a lot more about in the last several years. So I guess just in general, are there any special considerations that we need to take into account for a patient living with a rare autoimmune disease, if they're thinking about starting a family and maybe wanting to become pregnant?
Yeah, that sounds comfortable from my side. So, we don't know a lot about autoimmune encephalitis specifically, and contraception and pregnancy outcomes because it's rare. And I think we can infer from what we do know about other autoimmune conditions, and the relationship with vasculitides and vascular inflammation and vascular events directs some of what we would say about contraception. And everything that I'm going to say I would frame under the guidance of the human rights framework of reproductive justice, which is a foundation brought to us by a group of African American women in the United States who figured, this pro-choice, pro-life dichotomy does not define us, and it doesn't speak to us. And here's offering to the rest of the world a framework that will speak to everyone, and a human rights framework that guarantees the right to have a child, to not have a child, to parent your children in safe and healthy environments, and to enjoy sexuality as you determine it, really does speak to everyone. And within that context, decisions, it's a broad framework for people to make decisions and engage not only with healthcare, but with other opportunities regarding sexuality and reproduction. And within that framework, specifically to the medical issues regarding contraception, we can break the available options down to hormonal and non-hormonal methods. And I think for people with medical complexities, the non-hormonal methods are always great options, and basically never interfere with any medications. So things like barrier methods, as well as the copper IUD, but condoms, diaphragm, the cervical cap, and then fertility awareness methods. And there's really amazing options and that are developing and becoming more prevalent and more accurate. So lots of people, I imagine lots of your patients are already using menstrual trackers, and a bunch of those can be used to effectively predict ovulation. The egg has a basically 24-hour period post-ovulation that it can be fertilized. Sperm, unfortunately, from the contraceptive perspective, can survive 5 days. So there's a window essentially of a 6-day window where conception can happen. And fertility awareness methods can, especially accurate ones, can narrow that and more accurately identify that window. Anyway, and then regarding hormonal methods, the pill, patch, ring, and hormonal IUDs, the implant, Depo-Provera, the injectables, the ones that contain estrogen, combined hormonal contraception, the pills, are the most commonly used methods in the US, and I would recommend steering away from those combined methods that have estrogen, that are more likely to result in thromboembolism and other medical complexities, especially with people who are, and I say this as maybe, might have an increased risk of thrombosis and vascular events. I would also qualify everything that I'm saying as I am certain I am the person in this room that knows the least about autoimmune encephalitis and other autoimmune neurologic conditions. And then, as far as the hormonal methods, there are progestin-only methods. For example, the hormonal IUD, the implant, progestin-only pills, Depo-Provera, that are highly effective methods that are available to people. And at the top of the list for people who want to most effectively prevent pregnancy, the hormonal IUD and the implant are phenomenal, with pregnancy risk less than 1% per year, and would not interfere with medications or hopefully the disease processes for people. That was already a lot.
That's great. Thank you so much. And I guess, now more specific to a patient who might want to get pregnant, what types of things might they have to think about in terms of their autoimmune disease affecting their pregnancy, or maybe their pregnancy affecting their autoimmune disease?
And I think this is the perfect segue toward collaborative care and care teams. So there's pregnancy is, for nearly everyone, the most physically challenging event of someone's life who can have a pregnancy, and it is very much worthwhile to optimize outcomes, to plan for it, and to be as prepared as possible, especially if you have a medical condition. And there are well developed and comprehensive guidelines on preconception care. But being able to plan a pregnancy, which happens about half the time in the United States, is a strong predictor for optimizing outcomes, and especially important for people with medical conditions. So, optimizing management and making sure symptoms are as minimally impactful as possible, and then optimizing medications. And the immune modulating medications, pregnancy is also an immune modulator. And that, combined with immune modulating medications, can create some additional challenges. And people can do very well with these with the combination. And the other issues for pre-pregnancy care and preconception care apply to everyone. In addition to optimizing, the symptoms of your current condition and your medications, and evaluating, if there are risks that are going to impact pregnancy. But the rest of the things, I guess one area that would be of greater concern for people on immune modulators would be vaccination status, and where people are with that, and then monitoring, STI screening as well. And then the rest of the issues are really global for everyone, including optimizing exercise and target body mass index and weight, And being able to determine initiating pregnancy at a time where you're most likely to have the most successful outcome.
Great, thank you. Does anyone else have anything to add in terms of pregnancy and autoimmune neurologic disease?
I think the only thing I would add is to stress the importance of keeping in close contact with the physician that you're seeing, telling them maybe a year in advance or a few months in advance, hey, I really want to start trying for a baby. And this is kind of the timeline that I'm looking at. And this is the current medication that I'm on. With this medication, what do you recommend that I do? Is this something that needs to be stopped several months before conception or trying to conceive? Is this a medication that we can continue on throughout a certain period of the pregnancy? And it's going to be individualized. It's going to be based on the certain type of medication that you're on. And then the other really important thing is pregnancy is immunomodulatory, but the postpartum period is a really important period because you can have flares of whatever disease that you have. And so not only letting your physician know, okay, this is a timeline that I'm thinking about conception, but once you conceive, this is my due date. But also, once you deliver the baby, let your physician know, come up with a plan for immediate postpartum. What are we going to do during this immediate time period, the week after the pregnancy? Maybe you need to be on some steroids during that time just to get you through that period, but come up with a plan with your doctor so that once you deliver your baby, the postpartum period is not going to be a problem for you. It's something that you can get through safely.
Some resources at the University of Utah specific to these issues. So we have a clinic called CHIRP, Contraception for High Risk If Pregnant. A great place to for people who need care related to contraception, for people who have chronic medical conditions. And then a lot of issues can be handled by generalist OBGYNs and family docs and midwives. And when things get complicated, there is an area of OBGYN called maternal fetal medicine. And these are the docs who are most capable and most practiced in caring for people with complicated medical conditions and pregnancy. And just to lift it up one more time, a collaborative team approach is really, is always the best answer. Caregivers talking to each other between disciplines will always generate the best outcomes.
Wonderful. Okay. I think we have about 15 more minutes. So we wanted to open it up to the audience if anybody has any questions.
Maybe you could comment on which diseases get better during pregnancy and which ones are doing worse, and more on the postpartum period.
Yeah, sure. I'll just repeat the question for our online folks. So the question was wondering if we could comment more specifically on certain autoimmune neurologic diseases that might get better during pregnancy versus those that might get worse during pregnancy.
Yeah, so I think for some of the more rare disorders, we don't know. So to my knowledge, for example, MOGAD, I think there's currently a MOGAD in pregnancy registry to understand that more, if there's a higher risk for relapse, either during pregnancy or after. Multiple sclerosis, for example, is a lower risk of relapse. So that's, we think about these diseases a lot in terms of what we know about multiple sclerosis, because that's just what we know the most about. And so we know that what we talked about earlier in terms of that high risk period after pregnancy, we know that that exists with multiple sclerosis, this decreased risk of relapse during the pregnancy and then after. We see that a lot with NMOSD as well. So the the patients tend to do quite well during their pregnancy, but after pregnancy is a really, really high risk period. And so for a lot of patients, we actually infuse steroids after delivery, like before they're discharged, even in the delivery room, right after they deliver, are infusing IV methylprednisolone, an IV steroid, so that they're covered. And everyone has a little bit different approach to this, but we're highly concerned in that postpartum period, especially for NMOSD patients, because the relapses can be pretty severe. For autoimmune encephalitis and stiff person syndrome, the conditions are so rare, to my knowledge. We don't really know what happens during pregnancy. We can kind of speculate based on other conditions that the pregnancy might be a little protective during those time periods. There are reports of patients getting autoimmune encephalitis during pregnancy, so we know that it can happen. but for patients who have it, is there a higher risk for relapse before or after or during? We don't know. I don't know if you have any other comments on that.
Sorry, if I may. Yeah, and I wanted to modify what I had said before to say that, when speaking about collaborative care, right, like the driver of this is the person with the condition, and shared decision making. We don't have a lot of data for these things, and this is not like, oh, we know the obvious best treatment. There are options. There are lots of times when we're taking care of people with autoimmune disorders in pregnancy where there is a lot of guesswork. There is very little that is based on randomized controlled trials where there's a very clear decision. And nobody knows the condition better than the person who has it. And directing, being in a position and identifying caregivers who can help you essentially consume the information that they have and use it to make the best decisions is really going to, I think, optimize care in the end, as well as the sense of, the control and directing it.
All right, any other questions from the audience?
So just for having my daughter who is looking at colleges and stuff, applying, what is the reality, do you think, of communities being really aware? Like, you guys do patient days and different things, but that's one group of people. What is the reality of the awareness of things like autoimmune encephalitis in college communities, where there's support or help or even understanding as far as treatment if she missed classes or whatever?
Yeah, that's a great question. I'll just repeat it. So the question was, for a young patient transitioning into going into college, what does that look like? Is there awareness among those communities? And are there ways to access different supports throughout that college experience?
Yeah, that's a really, really great question, and something that a lot of patients struggle with in terms of deciding which colleges to go to. And sometimes that, part of that decision is, are there centers, how close are they to infusion centers or academic centers that might have autoimmune neurologists nearby, depending on how frequently they're going to be coming back. Sometimes patients stay with their pediatric autoimmune neurologist because they're able to come back, frequently enough to come home that they can still still see their autoimmune neurologist, and then gradually transition to an adult neurologist. So there's a lot of discussion surrounding that of how that could look, or if they might be staying, they know they're going to go to college somewhere and likely stay there, then finding someone that could transition the care over, that you could transition the care over to. And then, in terms of finding resources, it's going to be very similar in terms of the experience of schools and peers and neighbors and doctors, primary care doctors in general, probably not knowing a whole lot about autoimmune encephalitis just because it's a rare disease. And so part of it is going to be having to educate other people. So I know you guys probably know that you've had to do that and go through that process. So part of it is learning to advocate for yourself a little bit. But there are, similar to like 504 plans in that you do for school, there are ways to have your doctor write notes and do the same sort of thing of recommending resources during college classes and college years to try to make sure that education is successful. So still those resources available, but it might just feel like starting over again with different people versus the same people that you have every year if you're in elementary school or middle school or high school. It's just a new school to think about.
What's the role of telehealth, supporting people who travel?
Yeah, I do a lot of telehealth, so you guys know since you're not from Utah. And a lot of it depends on where where a provider is licensed in terms of what states they're able to do telehealth in. So that's why it's helpful to talk to your provider in advance and say, we're thinking about these schools or we're thinking about these areas, because we can help discuss and say, I'm licensed in that state, we can keep doing visits, or there's a great neuroimmunologist or autoimmune neurologist in this state. And so, we obviously want you to do what you want and go where you want to go, but we can also, if those factors are weighing on the decision for you guys, also can provide information. So just like all these things we're talking about, being communicative with your provider is helpful, because then we can, if we have more time to plan, the better, and we can really come up with a good plan for either continuing care or transitioning care, whatever works best for the situation. And figuring out infusion centers, all that fun stuff, insurance, all those great challenges that everyone goes through.
She thinks you better be licensed in Massachusetts.
I'll have to work on that.
Well, it's sort of fun if you can get the therapy every 6 months, or something that can be administered by the college student themselves. So if everything's going well, then they just come in for spring break and Christmas or holiday season, whatever it is. And then you see them multiple times per year, just like you would ordinarily. It's always nice to have that backup neurologist in the community that they can rely on.
Yeah, just a comment from the audience that, for some patients, their treatment plan could even be tailored depending on the timing of coming home from college and visiting family. So lots of different options, and it can always be individualized for the person. So, any other questions? All right, I think we'll conclude for today. Thank you so much. I think we're just right on time, so that's great. Thank you.